it's just a huge opportunity waiting to be tapped.
Like the hospital wants to know where their vehicle is. So the facility user portal that we use it with a bunch of our best paying hospitals and our aftercare centers.
Back to NEMT Experts, I've got Mike Borom with me, the owner of Ambiance Medical Transportation in LA. Mike, how you doing?
Great. How are you?
I have never been better. Mike, you run an NEMT business that focuses on hospital discharges, and you pretty much exclusively do stretcher trips for hospital discharges, on-demand NEMT for hospitals and facilities. It's a unique business model and a highly profitable one. Can you tell us your story about how you got into this?
Sure. So we bought this company about 5 years ago. And when we bought it, it had ambulatory, wheelchair, and stretcher. And about 90% of the business was from brokers. We did a whole bunch of math because I'm very analytical. I used to be in private equity. We didn't take the ambulatory business because they were losing money and they thought they were making money, but they never put any money aside to replace the cars. We took the wheelchair business because all the vehicles were set up to do wheelchair and gurney. But we pretty quickly got out of the wheelchair single driver business because it was brokers. We were making $27 a ride. You really can't make money doing that, or we couldn't figure out how to do it. So we exited that business. Because we exited that business, the brokers didn't want to deal with us because they wanted to balance, because they wanted to give the gurneys as a quote reward for their wheelchairs. So our business today is probably about 5% brokers, maybe 4% brokers, but it's really 3 patients, which are 3 dialysis patients. So we do no dialysis for brokers. We do dialysis for health plans that we contract with directly. And we do private pay dialysis. And some of the hospitals actually have dialysis patients, so we'll do those as well. We pivoted our model to go directly to the providers, and that would be hospitals, health plans, surgery centers, and aftercare centers. And we have a very strong direct-to-consumer private pay business as well. So those are what we do. We also do last mile air medical transport, where we'll pick the patient up on the tarmac at LAX and take them. So if they came in from Abu Dhabi to LA in a gurney on a plane, we'll pick them up off the plane and we'll drive them up to 500 miles to where they're going. And so that's kind of a unique business model as well. So we have all those elements. We really focus on where we can get paid to profitably do what we do. And we try to go where nobody else wants to go because it's difficult.
Well, that leads right into my next question, which is, obviously your business model in NEMT is unique. It's relatively a lot more profitable than the standard NEMT business model. And it takes a lot. It's difficult to get there, right? What you do is, fewer people do it because it's difficult to do. What would you say, Mike, are the most difficult parts of getting your NEMT business model to the way that it is now versus from, where it started when you bought the company?
So we used to be with another large dispatch system with our platform, which I won't mention, but that platform was really built for people who did brokered business and mostly appointments, dialysis and other appointments that for the preponderance of them get made well in advance, either as standing orders or the day before with doctor's appointment, but most of them get made well in advance. So you set your schedule, you figure out your schedule, you assign your drivers, and you go to bed, and the next morning you get up, your schedule's all done, and you're just running the day to your schedule. When we come in into this model, when we look at the day, so if I looked at tomorrow, I would have 3 vans that are going to be on the road because it's a Saturday, maybe 4. And actually, I have 6 vans on the road. tomorrow. And I will have 4 trips as of right now for tomorrow. That's my day tomorrow. I look forward, 4 trips, 2 patients, 4 trips. And so today when we came in, we have a nice white blank board.
In fact, Mike, do you want to share the screen as you're, I'll share your screen as you're describing it. So this is today so go ahead.
So if you go to tomorrow,
Mm-hmm.
we don't even have our vehicles listed yet, but if you listed them, there'd be no rides. Okay.
Right. We've got 5 rides here on the side, and there are 3 different patients here.
So that's it for tomorrow. That one patient will probably cancel. So we really have 2 patients. So if you back up and you look at today, if you go to the morning, our day really starts about noon. So we have some early morning trips, but for the most part, our day starts around noon because that's when hospitals and surgery centers start releasing patients. So no doctor comes in to do surgery, or not a lot of them come in to do surgery and outpatient surgery at 4 a.m. So they start around 9 and they finish around 12. And hospitals start getting their act together to release patients around noonish. And so starting about 10, 11 a.m., we start interfacing with our customers. We needed a system that would allow us to place those customers proactively during the day, show us real time what's going on. So a lot of times we'll go into a hospital and the patient won't be ready because the doctor hasn't filled the script. The doctor hasn't released the patient. Sometimes our crews get there and the patient has to go to the bathroom. So we have to wait till the patient goes to the bathroom. Then you have to do all that stuff. But we go bed to bed. We have security at hospitals. We have a lot of time in and out of hospitals to do that. And so we needed a system where we could see whether those patients were on time or not. And if they were slipping, how would we, in the middle of the day, juggle patients between vehicles, which we do a lot. Okay. And so we use Run Bambi Run to give us a proactive look at where they are. You'll see the patients are sitting over on the left on the board because we haven't put them out. But we deploy our vehicles throughout LA because our hospitals are throughout LA. And we have to be careful that we don't move a vehicle from, say, Torrance up to Mission Hills and then find out, oh, that patient slipped. So we kind of do everything last minute, and we use Run Bambi Run to help our dispatchers decide where to put those patients. And so we use Run Bambi Run pretty frequently. Our old system didn't have the ability to do that. We just had to trust that the guy who's just staring at the screen, and our old dispatcher used to stare at the screen and watch movies. So we had to trust that he was actually doing the best job. So the way they did their job was leave as much space between patients as possible to make sure that nothing really gets hard. And when we were doing that, we weren't making any money. So if you look at yesterday, we've adapted Run Bambi Run. So sometimes we'll tell a hospital, if they'll call us at 12 and say, we want you to pick up a patient at 2. Now we'll look at our schedule and we say, we can't guarantee 2, but we can guarantee between 2 and 4. They'll say, fine. We've set Run Bambi Run up so that it will know that that's a 2-hour window for that patient and let that patient slide. So when we run Bambi Run, it will say it's okay for that patient to get picked up at 3:45. And it helps us juggle the schedule. But if you look at how compact that schedule is today, that is way more compact than it used to be. And so we get paid a lot for those patients going in and out of hospitals because we never leave a patient. If we show up, we will hang. And if you're going to hang, you have to keep your other clients happy. So you have to have the ability to juggle everybody and bounce that around. And Run Bambi Run helps us do that.
Thanks, Mike. Yeah, it's a lot of managing just trips that come up on the fly and having the operational flexibility to be able to jump on all these trips that you don't know when they're going to pop up because it's all on demand. And that's why they're high paying, is because they're on demand. Mike, I want to get into the numbers if you're willing to share a bit. How many vehicles do you typically operate with on a regular weekday? And what sort of revenue numbers are you seeing per trip and per month and so on?
So we operate 9 to 15 vehicles on the road in a day.
And they're all stretchers, right?
They're all stretchers. A lot of them have ability to do a wheelchair. We do wheelchairs as favors for clients. Okay. And so if a hospital's in a bind and the broker can't get a wheelchair company to go pick it up, we will take that wheelchair patient for the hospital. Okay. But there's only, I think we have 3 customers we'll do wheelchairs for. And they're very good customers. So we make between kind of and we prioritize our customers. If you pay us less, there's a good chance you get bumped, and everybody knows that. So probably our lowest fare gurney trip would be about $180 for a 3-mile trip. And our highest fare would be $5,000-$6,000 for one of those long distance ones.
And when you say long distance, how long distance?
200-300 miles.
Okay. And what about the average trip?
So on average, our trips are about 7 miles.
Okay.
Ish, which doesn't seem like a lot, but we are in LA. So it's not like we're in Columbus.
Yeah. So what's the price for your average 7-mile trip?
$230.
Okay. Okay. So these are sizable numbers that you're dealing with compared to your average NEMT business by
the way, that
order.
That 230 will include some wait time because on average we have to wait.
Yeah.
Okay. So we built our model to say we charge you to wait, but we'll never leave you. The trips aren't long. Bambi lets me look in and see how long did I spend in the hospital, because I know when I arrived, I know when I'm supposed to be out. And if the patient's not in the van by that time, our dispatch is calling and saying what's going wrong. So we don't want to wait. Okay. We make more money picking up and getting done with the trip as quickly as possible than we do waiting a long period of time.
Yeah. Mike, did you just sort of figure this out as you went along about like, hey, how do I optimize the business to operate in this model? Or were there other similar kinds of medical transport businesses that you sort of took pieces of the playbook from?
This is pretty much from scratch figured out. It took us a couple of years to figure out the payer system. And it took another 1.5 years to get into the payer system. You know, surprisingly, one of our biggest competitors are ambulance companies, because we look at it as if you go into hospital and the hospital does what they're supposed to do, when you get released, are you non-emergency medical or emergency medical for the most part?
I mean, it's an open question, right?
Well, you would hope if the hospital's good, you're going to be non-emergency because they're releasing you to a lower level of care. So other than hospital transports to repatriate a patient, okay, any patient that leaves the hospital and goes to a lower acute care, like a skilled nursing facility or a long-term care or back home, 95% of those should go non-emergency. The only ones that don't go non-emergency are the ones that are intubated, and so actively intubated, or have an active IV. That's pretty much the only ones we won't take. If an ambulance company takes that patient and convinces the hospital they should take it as non-emergency BLS, they'll get paid $400 to $800 for that patient, up to $1,600 on the weekend. And if they call us, we'll charge them $250. Even if I charge them $300, it's a great deal for them. Okay, so they wind up, ambulance companies are measured on response time. So they hang around, they overstaff, and when they get called, it's how long does it take you to get there? That's because it's an emergency. We get measured on, did we show up? And did we show up in a timely manner when we said we would? And
so Mike, why aren't more non-emergency medical transport companies taking over this ambulance work?
It's difficult. One, it's difficult because there's lots of guys out there who, if you talk to a health plan, the health plan says we'll pay you $110 to do a hospital discharge. You cannot make money at 100. Maybe you can if you're two guys kind of find yourself a salary. Okay. But if you're going to be a professional company, you can't make money going into a hospital, getting a patient, leaving the hospital, put them in your gurney, taking them where they're supposed to go, unloading them, and then doing your next patient. And you certainly can't make it in LA. Okay. But there's guys who think they're making money. So it's difficult to penetrate this business because there's a whole bunch of people that don't know that they're like the snake whose head's cut off. They don't know they're dead. They're just still squirreling around. But eventually their vehicle is going to break down and they haven't put money aside. So they bought the vehicle, kind of work in the insurance game. The vehicle's getting older. The repair costs are going up and they haven't put any money away for the next vehicle. But they paid themselves a salary in the end, which really was the money they put into the vehicle in the first place. Okay. And so that's who you're competing against. And to convince an entire industry that, hey, you need to look at whether you're really making money for the long term as a company. Okay. And you want to be in this business in the long term, or you want to be in it for like 3-4 years.
Yeah.
And then go out of business. So I've never done it, but I'd be interested to look at the lifetime default rate of non-emergency medical businesses. Okay. In LA. Like how many people who were here 10 years ago are still here and how many are bigger? Okay.
Yeah.
And the company we bought from a guy whose head was cut off and he was swirling around and he lost $4 million. Okay. And so we basically bought the company for the residual value of his vehicles. That's it. But he spent $4 million trying to make it work. And I think there's lots of people doing that same thing on a smaller scale.
Yeah.
That's why it's hard. If your competitors aren't rational, it's hard to make money.
Mike, we have, several hundred customers on Bambi now. And I think you are still one of the only NEMT businesses that operates with your business model. And it's just a huge opportunity waiting to be tapped. Like you lay it out pretty simply. Like the ambulance companies will charge X amount for doing a ride. You could do non-emergency stretcher and charge the hospital less, and you win and the hospital wins. And it's just not enough people are tapping into that opportunity that's just there, right?
So if you look at patients in a hospital, the vast bulk of the patients in the hospital are covered by their insurance. So if you're an elderly patient on Medicare, like myself, and you go into the hospital, Medicare takes care of your hospital. When it's time to leave, okay, if you're still in a stretcher, let's say bedbound, unlike myself, okay, you're going to leave the hospital in a couple different ways. Somebody from your family is going to come and schlep you into the station wagon or the van. You're going to go into BLS non-emergency, which Medicare, if it gets through, will pay for. Okay. Or you're going to go non-emergency, in which case either the family or the hospital has to pay that bill. So the system set up, especially the Medicare system, to try and convince Medicare that this patient needs an ambulance because they cover emergency transport. Okay. What happens is Medicare either catches it right away and rejects it. Then the hospital contract says to the ambulance contract with the hospital says, if it's rejected by Medicare, you have to pay me the Medicare rate. Bam, $1,000. Okay. Or gets through Medicare. Medicare does an audit once every 6 years, and the hospital gets a bill for $1 million of rejected ambulance trips. The hospital freaks out. They look at the ambulance company gets that bill. They send the bill under their contract to the hospital. The hospital freaks out and goes, well, how did this happen? And they say, well, they rejected it. Well, they never should have put the guy in that vehicle in the first place. They should have taken their medicine up front. But it's really hard to convince somebody to take their medicine up front, even though in the long term, they're going to save the money. But once somebody gets sued, it's a lot easier sale.
And I guess you've been on the other side of that sale many times now.
So, well, we have. The other plus is, so that takes hospitals and sets it aside. The second part, which Bambi really helps us, I think the other thing you've got to think about Bambi is the hospital wants to know where their vehicle is. So the facility user portal that we use it with a bunch of our best paying patient hospitals and our aftercare centers. So they want to know, is the vehicle on the way? And it's interesting in aftercare centers because in LA, there's lots of surgery centers. And when they're done, the patient, if you go to a surgery center, plastic surgery, spine surgery, orthopedics, when you're done with surgery, they don't put you in a chair, they put you in a bed because they want you to start your recovery right away. Between that bed and where you're going, either to recover at home or an aftercare center where they're going to put you in a bed as well, a lot of people get stuck in a taxi or a black car or their family's car. Our pitch is, why wouldn't you consider your transportation part of your recovery and go prone, horizontal, in a bed? And so we sell that. And so we're part of the recovery. So you have to have a quality system in place, and you have to have a platform that allows you to manage it. So Bambi's a platform, and we've done a whole bunch of things around the quality system to let us do it. So we had done all the quality stuff. We just needed something like Bambi to help us get the rest of the way there. So that's why we use Bambi.
Run, Bambi, run.
But it is a unique model. It is. And it requires different marketing. It requires a different approach. And it requires you getting up in the morning and saying, I want to do this professionally. We, unlike probably almost all your NEMT providers or your customers, every single one of our attendants is an EMT. It's not required, okay? But we sell that to our hospitals. And we sell it not because it's an emergency. We sell it because an EMT has made a decision to spend money to be in healthcare. Our EMTs, we've had EMTs leave to become doctors. We've had EMTs leave to become nurses. We want our EMTs to go through, take this as a customer service opportunity. They spend more time talking to nurses than an emergency guy does. They spend more time understanding the hospital system than a true EMT does, an EMT for an ambulance company does. So it's a great way to get that kind of bedside manner going, okay? We take that and we sell that to hospitals because we think those individuals are more professional and have made a conscious choice to be in healthcare than somebody who got up and said, I'm going to take a couple online courses, figure this out, and make and get paid. So that's why we use EMTs, and we sell that all day long. So my guess is if I went into a hospital and pitched my business and my business model against the average person who said, hey, we've got a bunch of guys, they've taken online courses, they have first aid and CPR, and their long-term aspirations in health care are, I think we win.
Mike, I just love your business model. I love that you've figured out how to tap this opportunity from scratch, help the hospitals win, you win, and reduce these unnecessary ambulance expenses. Where do you take the company from here? Where do you see Ambiance Medical Transportation going in the next 1 to 5 years?
I think eventually we'd like to expand out to other locations. The problem is you have to understand the payer system and everywhere you want to expand to. So I don't want to go through that payer headache again. But if somebody was interested, we'd take them and say, okay, let's figure out a deal and we'll help you penetrate the market. I think the other element is in this, there's also just straight transportation you can do. So a lot of hospital systems want shuttle services and things like that, but they need you to shuttle either patients or staff, and they want you to be able to understand the hospital system and what's going on. So we're looking at doing that. And lastly, because I don't have to do this, but because we want to do it, we have a platform where we help communities basically subsidize Lyft rides. We're a partnership with Lyft, where we do 3,000 transports a month for communities in California that are subsidized for seniors. So senior pays 20% and the city pays 80%. And they basically get to use their Uber app or call our call center, and they get a true on-demand transportation. And if they need wheelchairs, because it's in LA, we provide the wheelchair service.
Well, Mike, I'd wish you luck, but I don't think you need it. You really figure these things out. So
I still don't like it as well as my other business. So,
and what's that?
We make a machine that rolls cannabis joints. So We make 60 joints a second.
Very nice. Delivering happiness on all fronts.
Exactly. Just like Bambi. Run, Bambi, run.